Vignesh, can you give co-host rights to Srinivas Murki sir as well? Srinivasmurki2001@gmail.com or Dr. Srinivas Murki. You can make him co-host. Yeah. Srinivas sir, good evening.
Yeah, hi. Abhishek, good evening.
Good evening, sir. Good evening. So you want to test the screen sharing?
Yeah. Yes, I was trying to do that. No, it's not being allowed. Okay. Is it okay? Can you see the screen?
Yes, sir. We can see the screen, sir.
And you can hear me.
Sir, we can hear you, sir.
Okay. Okay.
Good evening, doctors. Can we wait for a couple of minutes and begin the session?
Sure, Vignesh. Sure. We'll wait.
Good evening, everyone, and welcome to this webinar on Formula for Success of CPAP in preterms. I'm Kriti from Global Healthcare Academy. I'll be your host for this evening. So this webinar is a part of GHA's ongoing commitment and initiative to provide high-quality education and training healthcare professionals. We believe that it's important to stay up to date in the latest version and best practices. And we are excited to share this information with you this evening. CME webinars and workshops provide a collaborative platform for participants to network and learn from each other, and will also provide an opportunity for the professional growth. In this webinar, we'll discuss the neonatal ventilation course. We have Dr. Abhishek S. Aradhya as a moderator for today's webinar. We welcome you, sir. So we'll have presentation from speakers, Dr. Srinivas Murthy and Dr. K.S. Gautam. We welcome you, sir. After this presentation, we'll have a question and answer section where you can ask questions you may have. I hope you all make the best use of exclusive webinar and find out it's informative. And thank you again for joining us. Before we proceed, I would like to give you all a brief introduction about Global Healthcare Academy. GHA is India's leading medtech academy. At GHA, our paramount mission is to nurture a pool of competent and compassionate human resource catering to the ever-evolving needs of the healthcare sector. We firmly believe that technology is a key of unlocking the potential of learning, and it plays a very vital role in each step of our educational journey. Our core purpose lies bridging a crucial skill and knowledge gap that often exists between traditional education and dynamic requirements of the healthcare industry. To achieve this, GHA offers a diverse array of 5 academic verticals: allied healthcare, continuing medical education, global dental academy, global healthcare publishing, GHA conferences. Now, I'd like to introduce Dr. Abhishek Aradhya, the moderator of today's webinar. Dr. Abhishek Aradhya is a pediatrician and neonatologist practicing at Ovum Women and Child Specialty Hospital, Hoskote, Bangalore. He did his MBBS from Bangalore Medical College with the gold medal in preventive and social medicine. After graduating, he moved to Chandigarh for post-graduation in MD Pediatrics from India's premier medical institute, PGI. He worked as a senior resident in the same institute for 1 year. He also finished super specialization on neonatal and intensive care at PGI 2017. In the last 5 years, he has been associated with Ovum Hospitals. Currently, he is a neonatal director in all NICUs of Ovum Hospitals. I would like to now request Dr. Abhishek to take this forward.
Yeah, thank you, Kriti, for that kind introduction. So we welcome you all for second curtain raiser event today. And for today's event, we have, I think in India, if anybody, in South India at least, if anybody speaks about CPAP, so everybody remembers Srinivas Murthy, sir. So can we have his introduction slide, Kriti? So Srinivas Murthy, sir, we welcome you. So Dr. Srinivas Murthy, sir, as we all know, he doesn't need any introduction. So he has done a lot of work on CPAP for the last, almost I can say, 2 decades. So sir also is MD in pediatrics and DM in neonatology from PGI Chandigarh. So like we as students from 2010, he has always been an inspiration model for all of us, because after doing MD or DM from PGI, everybody would want to join a academic institute. Srinivas Murthy sir showed that you can balance academics and research even in a private center. He has been an inspiratory model for all of us, because all of us actually who do not have exposure or opportunity to join a academic center follow him. He's actually currently the co-founder and neonatology lead at Paramita Hospital. He has a strong focus and special interest on non-invasive ventilation and quality improvement, and he has over 100 published research papers in the field. So we are very glad to have him today. We welcome you, sir.
Thank you, Abhishek, and thank you everyone for bringing me here. And it's my pleasure to talk on a topic which is very dear to me, and that is continuous positive airway pressure. So I would request all the participants to be as interactive as possible, and please let me know if I need to repeat something, or if you're not able to understand something, let me know about it. So my presentation is on continuous positive airway pressure and how do we make it successful in all the NICUs of our country. So this I'm going to talk in a case-based manner, and we will discuss issues related to when to start using CPAP, what are the choices of delivering CPAP for newborns, how do we use, how do we start, how do we monitor, how do we wean, and when do we say baby has failed, and switch on to higher modes of ventilation, and what can be done to improve the efficacy and quality of care for babies on CPAP, and are there any learning options, and how all of us can learn more about CPAP from each other and also from experts in this field. So let's move to this case, and I request all of you to interact and give your answers as and when they are posed to you. This is a 28-weeker, 1 kg, around 1 kg girl child. Baby was born by preterm labor and 1 dose of steroid was given 6 hours prior to delivery. And we know that antenatal steroids have a huge role in preventing severity as well as incidence of RDS and all the other neonatal morbidities. So this baby has not got a complete course of steroid. The baby was born by C-section and there was no asphyxia. Baby had respiratory distress at birth. It was born in the periphery and it took almost 4 hours for the baby to reach our hospital. And he was shifted on nasal oxygen. And this is the scenario, I think, in most part of the country where you have outbound deliveries. And at admission, the baby's temperature was 36, so borderline hypothermia. The baby had significant respiratory distress. And we assess the severity of respiratory distress using Silverman-Anderson score. In the subsequent slide, we'll look at the baby and how this baby was having severe respiratory distress. So the saturations were 93% on nasal oxygen. So that means he's maintaining good oxygen, but he has increased work of breathing as suggested by your Silverman-Anderson score. Now in the next slide, you will see this baby, and this Silverman-Anderson score is a very useful method to assess the severity of respiratory distress. It has 5 components: the upper chest, lower chest, xiphoid, nasal flaring, and grunting. So these are the 5 things which you see when you're talking about Silverman. Upper chest is the chest when you see from the side of the baby is lying on the cot, you see from the side and see that how the chest and abdomen are moving up. If both are moving up together, then it is 0. If abdomen is moving up and chest is coming after abdomen, it is 1. And if chest is going up, if abdomen is going up and chest is caving in, becomes a score of 2. So lower chest is the chest below the mid-axillary line. Below the mid-axillary line, you are able to see retractions or not. No retraction is 0. Some retractions is 1. And you're able to see retractions below the mid-axillary line from the lower chest till the axilla, it is 2. Xiphoid is no retraction. Xiphoid is 0. Some xiphoid retraction is 1 and severe visible retractions is 2. This nasal flaring, which is not visible, is 0, and you're able to see from very coming near to the baby is 1, and if you're able to see from distance, it is 2. Grunting, no grunting is 0. Grunting heard with a stethoscope is 1, and grunting audible to the naked ear is 2. So maybe all of you can look at this video and then start putting on the chat box what is the Silverman-Anderson score for this baby. So look at the upper chest, look at the lower chest, look at the sternum, look at nasal flaring and grunting. So maybe all of you can attempt to give the score in the chat box. Upper chest, lower chest, sternum, nasal flaring and grunting. So looking at this baby, you know that, yeah, I've seen some of you have given the answers. Wonderful. Yeah, Gayatri has said 7, Manju 7, 8, Abhishek 7. So Sahiti 7. So yeah, around 7 or 8 is a score. But if you look at again, upper chest is almost 2. There is nasal flaring which is given from the side, so 2. And you can hear the grunt, so 2. Sternal is 1. Lower chest is probably 1. Upper chest is 2. So it is acted around 7. So 7 or 8 doesn't matter. Both of you are correct. So you have a significant respiratory score in this baby, saying that baby has very increased work of breathing. And fortunately, in newborns, this high score is a marker that his alveolar collapsed. His FRC is low. So we need to do something to open up this alveoli. And the best way to do is by giving some positive pressure through the nose. And that's what the baby is asking us. He's saying that my FRC is low, my alveoli are closing. Kindly give something to open my alveoli, and that something is giving pressure through the nostrils. So this baby is a candidate who is having respiratory distress from birth. And when he comes to us, is always having a Silverman score of 8/10. But however, if you see oxygenation on nasal oxygen was 93%, which is reasonably okay. So at the cost of work of breathing is maintaining saturation. Now this is the X-ray done immediately, and you can see here the baby was started on CPAP and X-ray was immediately done. What you can see here is a typical reticulogranular pattern and air bronchograms. The reticulogranular pattern is seen bilateral and air bronchograms are seen behind the heart. So a very preterm baby with respiratory distress starting from birth, having moderate to severe distress when he reaches us, and X-ray suggestive of RDS. Now the options what we have to think now is what respiratory support you want to start in this baby. CPAP, nasal IMV, ventilation. So maybe you can answer this. What do you want to start in this baby? This is a baby with us, a preterm baby with respiratory distress and moderate to severe distress, but maintaining oxygen on the nasal oxygen. So what type of respiratory support you want to give for this baby? Very good, very good. I'm so happy. All of you are saying CPAP and not ventilation. So this is a typical baby who requires CPAP. CPAP is continuous positive aeration pressure, which is given in the nostrils to keep the alveoli open, to help the alveoli open, and to decrease the work of breathing. And how do we give this support? We'll like to look at the subsequent slide. And what do we monitor in this baby? How do we give CPAP for this baby? And what to monitor is what we would like to look at in the subsequent slide. So all babies less than 35 weeks, if they have a Silverman score more than 3/10 at birth or immediately after birth, if the baby is less than 35 weeks, have their score more than 3/10, that is a candidate for giving CPAP or any other non-invasive respiratory support. This is called primary respiratory distress. And this baby already has 7/10. So he's a candidate typically for CPAP or non-invasive respiratory support. When we say non-invasive respiratory support, it could mean CPAP or nasal IMV. And one would prefer CPAP over nasal IMV because it is logistically easy and more cost effective. And CPAP can be given with bubble, ventilator, flow driver, and with different interfaces. So we have different methods of giving CPAP: bubble CPAP, ventilator CPAP, or a flow driver CPAP. And the interfaces also could be different, like there could be a mask CPAP, there could be Hudson prong CPAP, Argel prong CPAP, or a Ram's cannula CPAP. So let's look at this. So these are the three different machines with which you can give CPAP. This is a typical fish and tackle bubble CPAP. This is another bubble CPAP, and this is a ventilator CPAP. Now the machines are three different: ventilator, and these two are bubble CPAPs. Now the interfaces, if you see, it can be given with a Hudson prongs, it can be given with a mask, Drager mask, or it can be given with a Ram's cannula. Now when do you use what? So most of the time we prefer to use a bubble CPAP. But if you are in a tertiary care setup, it is better to use bubble CPAP and use the ventilator for babies who need other respiratory failure, who do not have good breathing efforts. Those babies who give ventilator, but babies who have breathing efforts, have difficulty in breathing, CPAP is the best therapy. And I said CPAP is more cost effective, easy to be done. The nurses can do it. The nurses need to learn how to give CPAP for all babies. So this baby would have been started CPAP in our unit and most of the unit, and you could have used a bubble CPAP or other machine like this. So what is required for a bubble CPAP is a compressed air source, compressed oxygen source, a blender, a flow meter, a good humidifier, and a pressure generator, which is a bubble CPAP in a bubble CPAP. And the pressure generator in a ventilator is the expiratory valve. Now, as I said, to deliver CPAP, you definitely require air, oxygen, blender, flow meter, humidification, and a bubble jar for generating the pressure. So these are the requirement for giving CPAP, and it can be given with any one of the interfaces. What interface you'll prefer? Whatever your unit is using more frequently. The more experience you have in using any interface, the better will be the outcome, lesser will be the nasal injury, more will be the efficacy. So we started with initially with the ET, that is a nasopharyngeal tube. Then we shifted over to binasal prongs, that is Hudson prongs. And of late, we are using the Ram's cannula because of the ease of use, and also Drager mask CPAP. We use in our unit Drager mask CPAP for less than 1 kg, and more than 1 kg, we use Ram's cannula CPAP. But when you're giving Ram's cannula CPAP, ensure that there is some amount of leak around the nostrils. Whereas in all other CPAP, the CPAP interface should fit snugly on the nostrils. So how do we give this CPAP, bubble CPAP? We will try to look at this in the video, and I will run the video. Maybe you can look at the video and see how you need to set up a bubble CPAP machine.
Most working professionals never reach their maximum potential because of these three mistakes. Number one, not communicating to senior management. The people who are taking decisions on your
hear the
they are not aware.
We can see, sir. We can see.
audio.
We can see, sir.
The preparation includes assembling the machine, bubble CPAP circuit, a cloth and a disinfectant for cleaning the machine, gloves and distilled water. Clean the machine with 2% Sidex or any other approved disinfectant. Clean the heater wire and temperature probe with a clean and soft cloth and sterile. Connect the machine to compressed source of air and oxygen. After washing hands and wearing clean gloves, open the
Screen is frozen. Doctor, you may want to replay once again.
Sorry, I didn't get it. You can't see?
Hello.
The audio was coming, video did not move, sir.
Okay, just let me reshare. Resume, stop share. 1 second. Can you see now, Abhishek?
Sir, we can see this one, sir, but video is not playing yet.
Now?
It's moving, sir, now.
Now it's fine.
Oh, it's fine, sir.
Preparation includes assembling the machine, bubble CPAP circuit, a cloth and a disinfectant for cleaning the machine, gloves and distilled water. Clean the machine with 2% Sidex or any other approved disinfectant. Clean the heater wire and temperature probe with a clean and soft cloth and sterilium. Connect the machine to compressed source of air and oxygen. After washing hands and wearing clean gloves, open the disposable CPAP circuit. Fix the water chamber onto the servo humidifier and fill it with distilled water. Use the autofill option of fixing the distilled water bottle to a stand for filling the water chamber. Fill the bubble chamber with clean or distilled water and fix it to a slot available on the CPAP machine stand. Now fit the safety device between the flow meter and the water chamber of humidifier using the green gas tubing. Now connect the blue inspiratory limb to the other port of the water chamber. To the other end of the blue inspirator limb, lock the white expirator limb of the bubble CPAP circuit. The second end of the expirator limb is connected to the bubble chamber. Fix the heater wire and the temperature probe to the appropriate slots available in the humidifier and the inspirator limb of the bubble CPAP circuit. Switch on the humidifier and set in invasive mode as shown here. Watch for bubbling in the bubble chamber. Set the FiO2 flow and pressure to appropriate level. Wait for the humidifier to display a temperature of 37 before connecting the circuit to the patient. So that's how you will set up a bubble CPAP machine. But few important things in that are one is you need to keep the humidifier in the invasive mode. Second is use always distilled water in the humidifier chamber. You can use distilled water or drinking potable water in the bubble chamber, and ensure that you use the correct slot for the temperature probe and as well as the heating wire. Now the next step is to fix the interface. Now you keep the machine ready and the temperature should be 37 before you connect the machine to the baby. Now obviously to connect the machine to the baby, we need to fix the interface. We will look at one of the interfaces here.
Do you know what will happen if you read
one book every week, let me share some 3 powerful benefits. First one, you will improve your knowledge.
In this video, we shall learn the fixation of binasal prongs for the delivery of CPAP to a newborn. Assemble the Hudson prongs of appropriate size, gloves, green sheet, scissors, rubber bands, safety pins, tegaderm, and few connectors. Find the Hudson prongs, Velcro, and connectors in the prongs kit.
I'll just try again.
Cut a strip of tegaderm. Open the Velcro, appropriate size, binasal prongs. In this video, we shall learn the fixation of binasal prongs for the delivery of CPAP to a newborn. Assemble the Hudson prongs of appropriate size, gloves, green sheet, scissors, rubber bands, safety pins, tegaderm, and few connectors. Find the Hudson prongs, Velcro, and connectors in the prongs kit. Cut a strip of tegaderm. Open the Velcro. Cut the soft Velcro which is to be fixed on the prongs. Cut the rough Velcro of appropriate shape which will form the base on the philtrum. Fit the soft Velcro onto the prongs on either sides of the prongs. Close the pressure pot on the prongs with a sterile cap. Fix the connectors to the prongs. Now fix the cap to the head of the baby, ensuring that the ears are properly covered. Fix the tegaderm and the rough Velcro on the philtrum to form a base as shown in the video. Insert the nasal prongs into the nostrils and fix them to the base. The soft Velcro on the prongs locks with the rough Velcro on the philtrum. Connect the limbs of the circuit to the ends of the nasal prongs. Now fix the connectors to the cap on either side using the safety pins and the rubber bands. The rubber bands are made in a figure of 8 for fixing the connectors onto the cap. Now give support to the tubings by placing a green sheet under them. Insert an orogastric tube and fix the end of the tube to the side wall of the incubator. Keep the end of the orogastric tube open. Now watch through the gas flow for any leaks in the circuit. Set flow and FiO2. water in the humidifier chamber, temperature on the humidifier, the heater wire and heater wire probes. Ensure that there is some distance between the prong and columella. The expiratory limb inserting into the bubble chamber. Watch for the bubbling and water level, and also check for the set pressure in the bubble chamber. So we have seen how to set the CPAP machine, and we have also seen how to fix the interface. So we know that we had a preterm baby who was having increased work of breathing, where Silverman score was 7/10, more than 3/10. Baby coming at 4 hours of birth, and the baby started on bubble CPAP. So we have seen we have to set the flow rate, we have to set the FiO2 and the pressure. FiO2, flow rate, pressure are the three things we set in a bubble CPAP. And we start with a flow rate of 5 liters, pressure of 5 centimeters, and FiO2 of 30% to start off with. So once you do that, like as you've seen in this baby, we have started with a PEEP of 5, CPAP of 5 pressure, FiO2 of 30%, and flow rate of 5 liters per minute. Now, immediately you need to see if the flow rate of 5 liters per minute is adequate or not by looking at the bubbles in the bubble chamber. If bubbles are there in the bubble chamber, which means that your flow rate is adequate. If there are no bubbles in the bubble chamber, you need to increase the flow rate or look for leaks in the circuit. Now, next thing is you need to see whether the retractions are coming down. So the moment you connect the baby to a CPAP, you will see that the grunt will disappear, nasal flaring will come down, and the retractions will start showing improvement. This is a sign showing that actually the pressure is going to the lungs and started to recruit the alveoli. Alveoli is opening up and the FRC is improving. So as the FRC improves, you will see a downfall in the SA score or a decrease in the SA score. And the third component of FiO2 you see after looking for CPAP pressure and FiO2 flow. And you should be able to maintain the saturation between 91 to 95%. Subsequently, so you wait for 15-20 minutes. And if your CPAP Silverman Anderson score is still more than 3, then you can increase the pressures. So you can go up from 5 to 6. The other things you need to look at are X-ray. If the X-ray is showing a good lung volume of 6 or more spaces, that means your pressure of 5 is adequate. So you don't want the baby to have a Silverman score more than 3, and the lung inflation on the X-ray should be around 6 or more. So if these two are there, that means your CPAP pressure is adequate. But if your Silverman Anderson score is still more than 3, that means you can increase the pressure from 5 to 6 or 6 to 7. So you continue to increase the CPAP pressure if the work of breathing is still high. The second thing is after your work of breathing is coming down, you look at the FiO2 to see whether it is able to maintain the saturation between 91 to 95. If your Silverman score is less than 3 and baby saturations are less than 91, then you increase the FiO2. But between FiO2 and pressure, remember that if the baby has low saturation and if the work of breathing is high or Silverman score is more than 3, you'll increase the pressure and not FiO2. Only if your Silverman score is less than 3 and saturations are low, then you increase FiO2 and not the pressure. So remember this, if there is hypoxia and increased work of breathing will increase the pressure. And if there is no increased work of breathing, but only hypoxia will increase the FiO2 in steps of 5. Now always look at the flow rate of 5 liters per minute is adequate or not by looking at the bubbles in the bubble chamber. If bubbles are there in the bubble chamber, means the flow is adequate to generate the pressures whichever you have set in the bubble chamber. So easy to understand. The pressure is what we are giving the pressure to open up the alveoli to increase FRC and decrease the retractions. Once you open up the alveoli, your oxygen is going to help you to keep the saturation between 91 to 95. So the crux is to open the alveoli, crux is to decrease the Silverman Anderson score. One more method is, suppose you have gone from 5 to 6, your Silverman Anderson score is still above 3. And if X-ray is showing RDS, instead of increasing from 6 to 7, maybe you can add surfactant and you can give surfactant through Insure technique or by Lisa method. What is Insure and Lisa? In Insure technique, what we do is while the CPAP is still there, we intubate the baby and put a ET tube and give surfactant And after giving surfactant, you do a T-piece resuscitation while the CPAP is still there. So whereas in LISA, you put a small catheter into the airway, give surfactant, and no need of giving the T-piece resuscitation while giving surfactant in LISA, because we're using a very small catheter which doesn't occlude the airway. So that's all. Once you have a respiratory score, work of breathing and hypoxia, our aim should be to increase the pressure. And before increasing the pressure from 6 to 7, see, there is underlying RDS. Apart from increasing pressure, you will give surfactant before going up further. For FiO2, you will increase only if there is no work of breathing and hypoxia is there. So that is what is shown in the lower graph. Okay. So this baby was started in bubble CPAP with binasal Hudson prongs with a CPAP of 5, FiO2 30%, and flow rate of 5 per liters, as we have seen in this case scenario. Surfactant was given because the baby was still having significant retraction, and X-ray was already showing RDS, so it was given by Ensure method. I know Abhishek will prefer LISA, but we still continue Ensure, and some student who are capable, we ask them to give by LISA. Over the next hour, the Sullivan-Anderson score started decreasing from 7 to 4. The FiO2 was still at 30%. Flow rate of 5 was able to generate the bubbles. And over the next 12 hours, this is what happens. You see the dramatic improvement. Silverman score has almost become negligible. So the baby's FiO2 was reduced from 30 to 25% because the saturation was always above 94-95%. Flow rate was continued on 5 liters because bubbles were seen in the bubble chamber. So what is the plan now? He's already come down on so he doesn't have much of retractions. He's able to maintain saturations. He's on a pressure of 4 and FiO2 of 25%. And luckily, this baby had a RDS picture on the X-ray, so he was given surfactant. And since he was less than 1250 grams, the baby was also given caffeine. And at the same time, every effort was made so that the colostrum from the mother was given into the mouth of the baby. And the baby was also started on minimal enteral nutrition, 2 ml too early. Right from admission, we were started giving feeds for this baby. So what is the next plan? The next plan is this baby should be started on HFNC or continued on CPAP. Suppose if this baby is more than 1 kg, this baby was 1040 grams. So this baby was, because he was on a CPAP of 4, FiO2 25%, this baby, and no retractions, was maintaining good saturation, the baby was shifted to HFNC. But if the baby is less than 1 kg, maybe the moment you remove CPAP, baby will go into apneas. Those babies who can continue to keep the baby on CPAP of 4 or 5 and decrease the FiO2 to 21%. Now, these babies may take about 24-48 hours to remove from CPAP, and some of the small babies less than 1 kg may continue to be on CPAP for maybe days and weeks till they can come out of CPAP. You continue CPAP of 4 or 5, even though FiO2 requirement is only 21%. Many of them require long CPAP for lung growth, for decreasing BPD, and but without any oxygen, and 25% he will maintain the pressure as will maintain normal retractions, no retractions, and good saturations. But if the babies have apneas after removal, you need to continue those babies on CPAP. So less than 1 kg, you can continue lower settings of CPAP, or more than 1 kg, you can switch over to HFNC. HFNC is nothing but you remove the expiratory limb, and to the tip of the expiratory limb, you add a special prong called HFNC prong, where in HFNC prongs, the catheter, the nasal prongs are very small. They occupy less than 50% of the nostril. There should be significant leak in the nostrils when you're using HFNC prongs. You should not use the CPAP prongs for HFNC prongs. And you should not use the HFNC prongs for delivering CPAP. So while you shift to HFNC, you can continue to keep the baby on 5 liters per minute and keep the FiO2 21%. And as the baby improves, you can come down on the flow rate from 5 to 4, 4, 3, 2 to 2. Once he's on 2, you can remove the baby into room air and continue the baby on feeding and increase the feeds and come to room air. So this is what is a success story in this baby who is a 28-weeker and 1040 gram. Now, the same situation may not be true for all babies. Sometimes we have to face with adults, but 85% of the babies who are between 28 to 34 week babies who settle with this site of CPAP and with surfactant, and most of these babies are successful. But 15% of the babies, we need to do something extra, and that is what we'll see in the next case. The same baby, we'll try to see what would have been the different scenario in this baby, and although giving CPAP and surfactant. So in the second scenario, what happened is the baby was started on CPAP with binasal prongs with the same settings. Surfactant was given by Ensure because RDS was seen on the X-ray. But over the next 3 hours, what happened? You can see here. The baby continues to have significant distress. CPAP score, because there was increased work of breathing, pressure was increased from 5 to 6 and then to 7. And even in spite of 7 pressure, we don't want to go more than 7. So the baby's FiO2 was increased gradually from 30% till 60%, and flow was continued to be on 5 liters per minute. So when you increase the pressure to 7 and FiO2 to 60%, there was a moderate decrease in the work of breathing by Silverman score coming from 7 to 5. So that was on Silverman score of 7 and FiO2, sorry, on CPAP of 7 and FiO2 60%. The Silverman score was still 5, CPAP was still 7, and FiO2 was consistently high. So what do we do now? You have a baby. This is the second scenario. We started on CPAP, but increasing pressure has decreased the Silverman score to some extent, but not completely. We wanted a Silverman score less than 3. So what do we do now? So maybe you can ask on the chat box and let me know if a baby doesn't improve completely like this, what do you do now? So Manish has said maybe you have to start nasal IMV. Let's see. That's an option. Very good. Somebody said do a blood gas and look for circulation, and maybe there is an acidosis. Maybe you need, if there is acidosis, you need to give fluids and also ensure that hydration is maintained. So yeah, there are very wonderful answers. So somebody said look for acidosis and correct the hemodynamics. Somebody said you can go to nasal IMV, think of a CPAP failure. Someone else said maybe you can give a second dose of surfactant because FiO2 is 30%. Somebody said look for complications. Yes. So maybe there is a pneumothorax which is there. That's why the baby is not improving. So you need to do a transillumination or repeat an X-ray and see if there is any pneumothorax. And somebody said ventilate. Okay. All these options are very good. But maybe we should go in the systematic order. So what we should do first is to see that whether what you're giving to the baby is actually reaching the baby or not. You're giving a pressure of 7, but how do you know that this pressure is actually reaching the lungs? So that you can know by looking at 2 things. One is the bubble should be seen in the bubble chamber. If bubbles are seen in the bubble chamber, the pressure of 7 is there in the circuit. But this bubble should reach the lungs. So you need to auscultate on the axilla, and you should be able to appreciate symmetrical bubble sounds heard in the chest. That means your pressure is actually reaching the lungs. So you have to ensure the pressure is reaching the lung. If the pressure is not reaching the lung, look for some obstruction in the nose. There could be secretion in the nose. That is why the pressure is not reaching the lungs. But if there are no bubbles, intermittent bubbles in the bubble chamber, then you maybe have to increase the flow or need to look at the circuit leaks or look at the leaks in the interface. So before doing anything else, firstly see whether your CPAP is delivered good to the baby or not. So what are the things you need to look? Pressure, look for the bubbles, hear for the bubbles. How do you know that the flow is adequate? There should be continuous bubbling, flow of 5. The flow is not adequate, leaks, collect the leaks and increase the flow. Still bubbles are not there, probably there is a leak around the nostrils. If bubbles are there, auscultate and see bubbles are heard, yes, the pressure is reaching the lungs. Bubbles seen, but bubbles are not heard. That means the pressure is there in the circuit, but not reaching the lung. Probably there is some obstruction in the nostrils. So you open up the nostrils, clean the nostrils, add some saline drops, and then you auscultate and see. And if the bubbles are reaching the lungs, you will be able to hear the bubble sound. And also look for humidification. On the humidifier, you should see temperature of 37. There should not be any water in the inspiratory limb, and there should be some condensation in the expiratory limb to say that actually you're giving a temperature of 37 and a relative humidity of 100% to the nose. That means you're giving warm and humidified gases to the nose. And that is what you have to do when you're giving CPAP for all babies. So 50% of CPAP is delivering the gases at 37 and with a relative humidity of 100%. Another 50% is delivering the correct pressure to the lungs. So ensure that your CPAP is delivered appropriately before you take another action of correcting the hemodynamics or going up more on the pressures or giving second dose of surfactant or NIV or ventilation. So the plan in this baby would be check for leaks. Bubbles are seen, bubbles are good, no leaks in the circuit. Bubbles are heard in the chest, air is reaching the lungs. Humidification, no condensation in the inspiratory limb, some condensation in the expiratory limb. The nasal interface, it should be snugly fitting. Mask or Hudson prong snugly fitting. Ram's cannula, some leak around the nostril should be there. Seal should be appropriate. Fixation should be appropriate. The prong should not be hurting the baby. The weight of the prong should not be on the baby's nose. So you need to support the tubings as seen in the video with some amount of gauze or a bed sheet tied up, and then give a support to the interface. And repeat X-ray and see for pneumothorax and see for lung inflation. And when we repeated the X-ray, you can see here the lung inflation was 7 spaces reticulocoronary was there, still persisting air bronchosderms was still there, but lung inflation looks reasonably good, but there was no pneumothorax. So what do we do now? They also did an echo and they said that there is a PPHN. So what can be done now? You know that you are delivering correct pressures. You know that lung inflation is good, but still some amount of RDS is there. So what do we do now? So we have taken care of the delivery. We have taken care of the pressure. FiO2 is reaching the lungs, but still baby is not doing well. So what do we do now? Yes, wonderful. Somebody has promptly answered. We can give a second dose of surfactant for this baby, maybe by Insure or Lisa, and then try to avoid the failure in this baby. This baby is a candidate for second dose of surfactant, but this baby also had a moderate to severe PPHN. So second dose of surfactant was given as suggested by one of the delegates here, and the baby was continued on CPAP, and PPH was managed by correcting hypoglycemia. Hypocalcemia was checked, so there was no hypocalcemia, there was no anemia, polycythemia was not there, and blood gas was done, there was no acidosis. However, the baby was given appropriate fluids, and since there was PPHN, the baby was started on low dose dobutamine and dopamine to keep the blood pressure in the normal range and to cause the pulmonary vasodilatation. So reflex vasoconstriction of the lungs was improved, inotropes were started, fluids were given optimized, and pain relief was done by nesting, cocooning, and also using a gentle stroking of the baby and covering the cap, and good temperature of the baby, and avoiding all pain relief for the baby, and also giving some minimal enteral nutrition. But in spite of that, baby continued to have retractions and low oxygen. So at this point of time, NIV was started for this baby. There are some people who may say that go for ventilation, but most people would prefer nowadays to go for nasal IMV, which is nothing but a surrogate of ventilation, where in ventilation we put the endotracheal tube, in NIV we put the prongs into the nostrils. So this baby, NIV was started as a rescue mode, as failed CPAP, and the NIV settings are almost similar to ventilatory settings. In this, you just need to see that the pressure is delivered into the nostril, so you slightly give slightly higher PIP and longer TI when you're giving nasal IMV. So this baby was given a CPAP of 5 to 6, PIP of 16 to 18, TI of 0.4, rate of 40, and flow of 6 to 8 liters per minute. And there was baby was looked for decreasing Silverman score and for chest rise and saturation maintenance. Now one can think of why this baby has failed CPAP. What could have helped in the baby preventing CPAP failure? There are a few things. One is that this baby has come very late to us at 4 hours. Now, if this baby was with us in the delivery room itself, we would have started CPAP. The moment the baby would have come to the NICU, we would have given a surfactant. So early CPAP, early delivery, early CPAP, early surfactant can prevent CPAP failures in these babies. And 1 or 2 doses of surfactant given early can prevent respiratory failures and going from CPAP to NIV or to ventilation. So early CPAP and early surfactant is what we all should aim. The moment you have a baby, preterm baby, less than 34 weeks with distress, you start the baby on CPAP, irrespective of the oxygen saturation, irrespective of the FiO2 requirement, and deliver surfactant if the baby is less than 34 weeks and requiring FiO2 more than 30%. So the baby is on CPAP, requiring FiO2 more than 30%, and or X-ray suggestive RDS, give surfactant early so that you can prevent respiratory failure in this baby. But again, you have to ensure that your CPAP is delivered properly. So for that, you think of flow, bubbles, FiO2, saturation, pressure, bubble seen, and bubble heard. Your interface should be appropriate. Baby should not have any pain. There should be cocooning, nesting, and developmental supportive care given, and prevent nasal injury. Always have a orogastric tube in place and feed the baby. The babies are much quieter if you start feeding them early. So just to summarize what we have done in these 2 cases, we have seen that CPAP is the primary respiratory support for all babies, preterm babies with having respiratory distress. All babies, preterm babies less than 35 with SA score more than 3, we need to start them on CPAP. CPAP also can be used for recurrent apneas, and when you extubate the babies from NIV to CPAP or from IMV to CPAP also, we extubate as a rescue, as a post-extubation mode. NIV can be given if facilities exist. Some people use this as primary mode, but we prefer to give CPAP as a primary mode. HFNC, I don't think should be used as a primary mode. If the babies have significant work of breathing, CPAP is the best, but HFNC can be used as a weaning mode from CPAP in babies more than 1 kg. Less than 1 kg, I would prefer to continue the baby on CPAP till your apneas are settled, till the lung growth has started. What all can we do to improve the efficacy of CPAP? And on average, you can see in your unit, if your failure rate is more than 15%, there is always a chance for us to improve on the delivery of CPAP in our babies. You need to work on improving the appropriate interface. So all three are good, but what you use, you continue to use to develop expertise in this. And prefer to use bubble CPAP machine because it's easy, cost effective. But whenever you have to use bubble CPAP, you have to ensure that you need a compressed air source, compressed oxygen source, and a good blender, and a good humidifier which delivers oxygen, air oxygen 37 with 100% relative. Don't compromise on any one of this if you want good efficacy of CPAP. Ensure appropriate humidification. That means the temperature should be 37 and there should not be any water in the inspirate limb. There should be some water in the expirate limb. Monitor the baby, the interface, and the machine continuously. We'll show you a monitoring chart and simplify the settings. Most of the babies are going to be good on a pressure of 5, flow of 5, FiO to 30%. Babies don't improve, you add on surfactant. And more than 75 to 80% require only these settings and surfactant. Very few babies require slightly higher pressures and probably a second dose of surfactant. But failure rate should be as low as possible. Always think of the troubleshoots. Some of them we will try to discuss in the next slide. And always use adjuvants like surfactant, caffeine, and feeding, colostrum, developmental supportive care. This should be part of CPAP care. Backup ventilation can be available if you are doing only CPAP in your units, or have some tie-up with a tertiary care unit so that if the baby fails, you can shift the baby to higher centers. So whether it is Hudson prongs, Drager mask, or Ram's cannula, all are good choices. Only choice you have to understand is in Hudson prongs and in Drager mask, there should be a snugly fitting, no leaks around the nostrils. But in Ram's cannula, it should not snugly fit. There should be 80% fitting. There should be some amount of leak around the nostrils. Good CPAP machine should have a blender, compressed air, compressed oxygen, a flow meter, a good humidifier, and a pressure generator like a bubble CPAP generator. So in flow drivers, the bubble generator is replaced by an interface which delivers a pressure at the interface. And to improve the efficacy of CPAP, as soon as the baby is stable, you can switch over to kangaroo mother care with CPAP. This is going to be the best thing which can happen to a small baby. If you are able to deliver CPAP with kangaroo mother care, your success rates are going to be very, very high. So this is a chart you can see here. On the top, you have what you need to monitor in the baby: the respiratory rate, heart rate, capillary refill time, Silverman score, breath sounds in the axilla, urine output, abdominal girth, CPAP pressure, FiO2 and FiO2. On the down, you can see the patient end, what you need to monitor, the distance between the interface and the columella. The nose is blanched or not. Columella, how is it? The nasal secretions. On each shift, one has to open up the prongs and add saline drops and clean the nostrils. And OG tube should be in place. And the tip of the OG tube should be above the level of the tummy. And as far as the machine, you need to constantly monitor for bubbles should be seen in the bubble chamber. The temperature should be 37 on the humidifier. The tubings always should be level of the baby below the level, and the flow rate should be 5 liters per minute. So this is a simple chart I'll share with Abhishek. Maybe you can hang it on all your NICUs and SNCUs so that you can simplify the use of CPAP, how to start, how to monitor, how to wean, and how do you look at the troubleshoot. The troubleshoot is there in the bottom right. I will show you the troubleshoot in subsequent slide. This is the troubleshoot. If the baby has hypoxia, increased work of breathing, that means some way the pressure is not going to the lungs. So either your pressure is not generated, that means your bubbles are not seen, or if the bubbles are seen, the pressure is not reaching the lung, that means there is a tube block, or the last thing is, yes, there could be something wrong with the lung itself that you need to give more pressure. But there is hypoxia, no retractions, that means baby's pressure is reaching, but oxygen is not reaching. So not reaching the blood. That means there could be a heart disease, there could be a PPHN, or there is a primary problem in the blender. You are giving 30%, but baby is getting only 21%. That could happen if there is a blender malfunction. The third condition is the baby is having work of breathing, hypoxia is there, air entry is not there, no bubbling. That means obviously once you see there are no bubbling in the bubble chamber, definitely the problem is in the leaks or your flow rate is inadequate. Regarding the humidification, if you see condensation in the inspirate limb, that means your temperatures are so low. These machines are likely to work in a temperature of 26 to 30. So the humidifier is likely to work best in 26 to 30, or your inspirate limb heater wire is exposed to the radiant warmer. That also can be reason for condensation in the inspirate limb. So you cover that distal part of the inspirate limb with a gauze or avoid the radiant warmer coming on that. So if there is no condensation in the expirate limb, you should expect some moisture in the expirate limb. If there is no condensation, that means humidification is not adequate. So maybe there is no water in the bubble chamber or jar or humidifier chamber, or your room temperature is very high. That is why there is no condensation in the expirate limb. So the success formula about CPAP is antenatal steroid, if possible, should be covered. The delivery should preferably in a tertiary care center so that CPAP and surfactant can be given as early as possible. And early CPAP, early means not less than 2 hours. Early could be 5 minutes or 10 minutes, as early as possible. Baby less than 35 weeks, distress, Silverman score more than 3, start CPAP. Don't look at anything else. Surfactant, if the baby has on CPAP, if FiO2 is more than 30%, X-ray suggests of RDS, give surfactant with CPAP. You can avoid failures. So have a good machine, good interface, and good monitoring and good troubleshoot. And I would end by saying, more than all this, the most important is the person standing by the baby, that is the nurse. So the nurses have a huge role in improving the success of CPAP, because CPAP is done most of the time by the nurses. They know how to start CPAP, how to monitor, how do we say that CPAP is not successful, how do we ensure that the interface is fixed properly. And that is why the success of CPAP is nurses, and nurses training is very important to ensure that most of these babies are not going for nasal IMV or ventilation. So thank you all for giving me this wonderful opportunity. I will request Abhishek to put the poll, and then we'll have the questions.
Vignesh, can we have the polling questions?
Yes, doctor.
I think the polling will come on your screen. You can actually answer that.
Can we share the results, doctor?
Yeah, please. So I know that wonderful audience, I think very learned audience, and most of the answers are correct. Yeah, but obviously there are some things which always need to be improved on. So we should always see it as an opportunity to improve rather than wrong answers. So for a baby on CPAP with low, so can we go one by one?
Just a minute.
So maybe they can all introspect rather than giving the answers. Maybe they can look at the slides again, and maybe they can go through the video. I think they'll be shared with the video again. Abhishek?
The video is saved, sir.
Okay.
Yes, the video is saved right in the YouTube channel of GHA.
Yeah. So I think they can all.
Yes, doctor.
So first one, I think it is wonderful. Most of us has done very good. 97% said Silverman Anderson score. Actually, that is the true answer. And luckily in preterm babies, we have a very good method to see whether baby's work of breathing is increased or not. And this score is wonderful to help us to assess whether we need to give increasing pressures or not. Next. So the second one, yeah, so should be able to deliver CPAP to the nostrils. It is single choice, so all obviously each one is correct, but obviously the answer is all of the above because each one is correct. I'm sure some people are in a hurry to answer one by one, but if you have read all the four, then you know that the fifth is the right answer because all are correct. Next. So adjustment of CPAP settings, we have said pressure, work of breathing is pressure, retractions means you need to increase the pressure. Forget about everything else. And if your saturations are 91 to 95%, you'll increase FiO2 only if there is no increased work of breathing. Only if your SS score is less than 3, they'll increase FiO2 if saturation is between 91 to 95%. And obviously, there are no bubbles in the bubble chamber. First, set the leaks and then increase the flow. This is a wrong answer. Humidification, there should not be any condensation in the inspiratory limb, but there should be some condensation in the expiratory limb. Then only we know that baby is getting 100% humidity. Next. Yeah, the last one for a baby on CPAP with low hypoxia and retraction. I'm sure most of you have done wonderful and so happy that the enthusiasm was good. I could see a lot of enthusiasm in all the people who have attended this. And I will try to answer some of the questions. Maybe Abhishek, you can ask the question so that I can answer.
Right, sir. So the question is by Gayatri. She's asking that humidifiers normally have a invasive and non-invasive mode.
So,
we discussed that in preterm we need to use a invasive mode. So she had doubts on that.
So whatever be the respiratory support in newborns, whether it is preterm or term baby, current consensus is we have to use invasive mode of humidification. Whether it is ventilation, HFNC, or whether if it's a CPAP or NAV or IMV, in all the ventilator or respiratory support, you should use only invasive mode. The current science is that maybe the science will change, but current all you have only invasive mode for newborns. Humidification should be only in the invasive mode. Yeah.
So is it the same for term babies as well, or only for preterm?
Whether it is term or preterm or first 2 months also, I would suggest it should be only invasive mode.
Invasive mode. So second question by Gayatri itself, she's asking, is mask preferred or the RAM scanner is preferred? I think you answered partly.
I think explicitly we said that explicitly we have said that irrespective of irrespective of the interface, it is the man or behind the interface who is more important, but all are good. Binasal interfaces, all are good. CPAP prongs like Argel prongs, Hudson prongs, dagger mask, Medin mask, all are good. So it all depends upon how experienced you are. There are some units who continue to use the same interface. Some who keep changing, but it all depends on your nursing care. Yeah.
They're asking what's the time frame to escalate from CPAP to NIV in case of failure? Time frame they're asking.
There is no time frame. It is all dynamic. So you need to, before saying failure, you need to ensure that everything possible has been done as far as CPAP is concerned, as well as surfactant is given, caffeine is given, developmental supportive care, everything has been done. In spite of all this, if the pressures or requirement is more than 7, and if FiO2 requirement or is more than 60%, or if the baby has recurrent apneas, or if there is hemodynamically unstable, then only go for ventilation. Otherwise, priority should be to continue on CPAP.
How frequent to change ventilator circuit, especially the bubble CPAP circuit and bubble chamber water?
Luckily, currently, if you're using disposable, there is no need for you to change these circuits unless they look bad.
So the answer is there's no need to change. Yes. So can we give surfactant on day 2 to day 3 if the baby is not improving on CPAP?
I couldn't hear well, Abhishek, your question.
So can we give surfactant on day 2 if the baby is not improving on CPAP?
I think this is very important because in India, we get the babies on 2nd and 3rd day. They continue to be on CPAP or nasal IMV for long. So surfactant has not been given. I have seen many babies improving by giving surfactant if the baby has RDS. So whether 2nd or 3rd day also we have given surfactant and babies have shown dramatic improvement. Although Western world says that after 24 hours, it doesn't have much effect, but always go on surfactant and CPAP rather than going for ventilation. Give a chance.
How can we protect from nasal injury and prevent nasal injury?
So I said some very important points is that the prong should be snugly fitting. There should be a distance between the columella and the interface, and always ensure the tubes are supported by something. And next is have a orogastric tube in place. And every shift, the nurse need to massage the nostrils at least 2-3 times, and also ensure that some saline is put into the side of the interfaces. And maybe in each shift, the nurse can check whether for hyperemia or blanching, early phase of nasal injury should be identified so that it doesn't go in for severe nasal injuries.
So there's a question on cannulate. Do you use cannulate?
Yeah, as I said, cannulate can be used for babies on Hudson prongs or other interfaces, but don't use it for Ram's cannula. Because if you're using Ram's and cannulate, if you're giving 100% seal, it is going to be a problem. And Ram's mechanism is different. So Ram's can cause stomach rupture if you use cannula and tight seal. The seal should not be more than 80% when you're using Ram's. So other interfaces, you can use cannulate to keep the interface snugly fitting.
What is the role of point of care lung ultrasound in bubble CPAP?
What is the role of?
Point of care lung ultrasound. Lung ultrasound while giving CPAP.
I don't think it has much role in the management of babies with CPAP. It can help you to make some diagnosis before you get an X-ray. Maybe you can know whether it is a pneumonia or a RDS or a pneumothorax. So I think apart from this, I don't think lung ultrasound is going to help you. You can do most of the time clinically you can make out whether it's pneumonia, RDS or pneumothorax. So lung ultrasound is just an add-on.
There's a practical question like post surfactant, if you're delivering same PEEP, is there a risk of pneumothorax? I think the answer is yes.
No. So that is why you have to keep on monitoring the baby. And if the chest rise is good, if retractions are coming down, you should start decreasing the pressure then. So don't wait for the baby to say that I don't need CPAP. So we need to be sitting by the baby, and then somebody needs to monitor the baby and see that the pressures are brought down once surfactant is given, and if retractions are less than 3 and saturations are above 94, 95.
Most of the questions we have covered. So there are some of the DM students who have joined here, as well as some researchers who have joined there. So do you think in the next 5 years, what will be the research gaps or prominent questions for us to answer in the area of bubble CPAP?
So I think one of the important gap is delivery room CPAP, humidification in the delivery room, obviously, and also starting CPAP, intact cord resuscitation and intact cord CPAP while you start CPAP and then you cut the cord. So these are some important things which can be shared on. And now we have cost-effective transport CPAPs. And now what TPs you're using gives you 100%. It doesn't have inbuilt air. So we have come out with a innovation where you have an inbuilt compressor, you have an inbuilt FiO2 monitoring, and it just requires oxygen connection for delivering CPAP with air oxygen, and also maybe add-on humidification will help in the immediate few hours also. The other thing I think we still need to innovate, and how do we convert this RAM scanner into a better CPAP interface? Maybe you can all work on improving the efficacy of RAM scanner CPAP. Apart from this, I think, yeah, there are some new machines coming on called Neonatal, which converts a bubble to a NIV. So just it has a float. The float goes up and down, and then you can generate two pressures. You can give BiPAP or NIV with bubble CPAP machine. So these are some innovations, and maybe more work is required before they become routine. Yeah. Abhishek, you're muted.
So what's the minimum and maximum PEEP range we can give?
I think, see, all these are variable with respect to the baby. But if a baby has respiratory distress, I think 5 is the minimum. If the baby doesn't have respiratory distress or baby has improved, 4 is the minimum. Less than 4, I don't think we will be giving CPAP for the babies. The maximum, we use up to 7 or 8, but less than 28 weeks, maybe 8, 9 or 10 is also possible. But in the Western world, they go up to 10, 11, 12 also. But these are very small babies, like 25, 26-weeker babies, where they tolerate slightly higher pressures because the lungs are stiff and alveoli are still not well formed. So, but in our units, which are 28 to 34 weeks, pressure of somewhere between 5 and 8 is what most of us are comfortable with. And FiO2 up to 50% and not more than that.
There's a question on, they're asking comment on indigenous CPAP being used in resource-limited settings using a chest bag.
So I'm a big no for that, although I was one of the proponent in the initial few years when I started my MD and DM. But I would suggest that now you have good machines which can give you blended air oxygen and good interfaces and also good humidification. So don't compromise. You will get immediate results, but over time, the baby is going to deteriorate by having pneumothorax and by having secondary infections. So it will give you some relief, but overall outcome is not very good without good humidification and without good blender and compressed air source. So the harm is going to be later. So preferable not to use indigenous methods. If it is indigenous, I mean, if you are talking about indigenous, it should have compressed air source, compressed oxygen source, and blender, and a good humidification and a bubble chamber. So you can make it all three, it is good, but that should be the indigenous concept.
The second question on humidification. So Sneha feels, what are the troubleshoot in humidification? Despite everything, sometimes it won't give appropriate temperature. What's the role of heat compensation?
So what happens is most of the time you are using auto flow nowadays, and you have to ensure that the flow is constant. So you need to keep that jar high up so that the water is continuously flowing. So the distilled water bags which you use should be high up, and there should be air venting so that the continuous water is there up to the optimum level in the humidifier chamber. Low level, high level of water in the humidifier chamber does not give you adequate temperatures. Second is your room temperature should be between 26 to 30, never too low and never too high. I've seen a NICU temperature of 18 or 20. That is not going to be comfortable for the baby as well as for the humidification. Third is the tip of the temperature probe in the distal end of the temperature probe, which is in the inspirator limb, that should be always be covered. And preferable is to keep that. If it is under warmer, you can keep it under warmer, but cover it up so that the radiant warmer is not heating the temperature probe. And beyond the temperature probe, whatever segment is there, that should be in the incubator, because that segment, you don't expect the loss more than 2 degrees Celsius. The loss is more than 2 degrees Celsius in the last segment, there is going to be condensation in the inspirator limb and the non-heated part. So these are some simple but effective methods of optimizing humidification.
There's a question on reuse, ET or autoclave. I think it's a very difficult question to answer.
So yeah, I think, but see, all this is optimization. So if you feel that, suppose you have used the circuit for 4 hours or 12 hours for a baby and the circuit is good. So, but before, you should know the principles of ETO. ETO will not work if it's a wet circuit. It has to become dry. It has to be clean. The circuit has to be clean and dry before you go for ETO. Cleaning is a mandatory thing. You can't use the same circuit for every baby. You will transmit infections. So if you follow all the rules, maybe 1 or 2 babies you may use and then prevent reuse. But I'm telling you that we are not resource poor. We use inadequately, we use resources. So, and the crux is actually having good nursing care rather than all this. You will have everything if you want it, but I think nursing care is the biggest challenge, and that is where all of us should work on to improve the care of babies on CPAP or all NICU babies.
The question from Mahesh saying that how long we can wait for the second dose of surfactant after giving the first dose.
Previously, they used to say 4 to 6 hours, but I believe that if you're given a surfactant, you should start seeing the results within half an hour to 1 hour. And within half an hour to 1 hour, if you're not seeing the result, you think that RDS is still prominent, maybe you can go for another dose of surfactant. The earlier given, the better are the outcomes. And crux is keep the lung open, avoid ventilation.
So is chest X-ray mandatory before administering surfactant?
What is it?
Chest X-ray mandatory before administering surfactant in RDS?
Blood gas?
Chest X-ray, sir. Is chest X-ray mandatory before doing?
So if the diagnosis, suppose you see a 28-weeker or a 30-weeker, I don't think surfactant is mandatory, because those babies are likely to require 1 or 2 doses. But if you have a 34-weeker on CPAP and you're given a surfactant, you're thinking of RDS, things have not improved, then X-ray should be repeated, because it will help you to see whether the pressures are actually reaching our lung or not, or there is something else is there. Sometimes there could be pneumonia, sometimes there could be a small pneumothorax or a mediastinal emphysema. So you need to look at all that before you say that, okay, it is the CPAP which is not working or RDS is the primary reason.
I'll take one last question. What is the ideal height of bubble chamber above the ground?
Just keep it above the ground, but below the level of the baby.
There's a question on one last question. I think they're asking question on prophylactic surfactant in a 24-weeker.
So I think we have good number of studies. The 2 major, one of the COIN trial and the other it's stuck.
Support trial, Bond trial.
No, not Bond the COIN and support trial. Yeah, COIN and support trial are the ones which have said that in COIN it was an early rescue. In support it was prophylactic CPAP. So ultimately the meta-analysis says that it should be early rescue CPAP, not a prophylactic CPAP. So prophylactic CPAP is not good. If the baby shows even the mildest sign of respiratory distress, you start CPAP in extremely small babies. But don't do unnecessary CPAP. Kyun karna hai? Jarurat nahi hai. Baby, the baby is not having good. If a baby has good FRC, doesn't have retractions, why do you want to give CPAP? Baby will ask for you to later, probably. Yeah.
We'll close the question answer session there. I think most of the questions are repeating. They're asking if you're using CPAP, if you want to give PEEP of 4, is it inside delivery 4 or outside 4? What number should be visible in a bubble CPAP is their question.
So whatever is seen at the tip of the jar is what is the level. And you can cross check it by seeing the water level. From the water level, it should be 4 centimeter down. If it is visible 4, tip is the above the jar 4 is visible. From the, you can actually measure from the water column 4 centimeter is down or not. So whatever is visible on the tip is the actual value, because that is what will display how much of the tube is inside water is displayed on the bubble jar.
Another practical question: role of safety valve in the bubble CPAP circuit.
It has the safety valve has 3 components. One is a safety valve which opens up at 17 centimeter pressure. So if the pressure in the circuit is more than 70 centimeter, it pops off. It will not give the pressure anymore. Second is the second middle port is for looking at the pressure. If you have a pressure manometer, you can actually see the pressure in the circuit by putting your manometer there. The third port is you can open up and put your FiO2 monitor to see whether your blender is working well or not. And what you set on the blender should be displayed on the FiO2 monitor. So the top one is a pressure relief valve. The middle one is for pressure monitoring. The lower down is for FIO2 monitoring. Anything else, Abhishek? Yeah.
That's it, sir. I think most of the questions we have covered. We thank you, sir, for a wonderful session on formula of success for CPAP. I think last time also Gautam Suresh sir mentioned that in India, actually, the challenge what we face is our residents or fellows or doctors are trained in ventilation, while our nurses are not trained. Possibly your class actually opened up that as well again. So we need to train our nurses as well on ventilation. Then probably our success is going to be maximum while using ventilation. Thank you, sir. So for giving us this talk. Over back to you, Kirti.
I would like to thank everyone for joining us today for the webinar, especially the speakers for sharing us the valuable and helpful information with the viewers. And there are upcoming courses which are launching on this November first week. So please have a minute to go through it. And thank you again, once again. So happy weekend for you all. Thank you.
Thank you, everyone.
Thank you, everybody.